Hi, my name is Christina Castro.
And this is Jono Casimir.
And I'm Gabby.
And we are here with
Talks with Therapy.
Before we jump into the content of the podcast, a quick disclaimer. The views and opinions expressed are solely those of the authors and do not necessarily reflect the official policy or position of any affiliated organizations, employers, or institutions. This content is intended for general information and or entertainment purposes only and should not be considered professional advice of any kind. While every effort is made to present accurate information, all thoughts and perspectives shared are personal and subject to change as new insights are gained. Now, let's jump into the podcast. All right, so welcome back to Talks with Therapy.
Episode 1. Woo! Let's go. Episode
Welcome back. So we are going to be talking about interdisciplinary collaboration and how important it is for our field. Kind of a little bit of what it looks like today. What are some of the problems, right?
Okay, so I work at a SNF, for those that don't know, a skilled nursing facility right now. So interdisciplinary will look like me as a physical therapist working with occupational therapy, speech therapy, nurses, doctors, people that come in for prosthetics and stuff like that. Anything to kind of help benefit that patient. I guess you work in home health. How does interdisciplinary look to you, Gabby?
So in home health, I feel like I work very independently. Most of it is communicating via email, phone call, text. But I have ran into nurses, and just the other day when I was arriving to a patient's house, occupational therapy was leaving. So we were able to chit-chat a little bit about the patient, things that we both see, because sometimes it's hard to reach out to someone else. Mm-hmm. Maybe the company may not always give you another clinician's information for, reasons that I think I could understand. But when it comes to collaborating, and I think that avenue has to be open, because if I observe something, who else do I have to compare that to?
Exactly.
So there's not a whole lot, but I have ran into it.
Mm-hmm.
So I take my opportunities when they come to me, and I'll bring up, hey, do you see this? Because this is what I'm getting.
Okay.
So I think in the home health setting, it's a little different. But still, I've had patients who are on speech, on occupational therapy, and so yeah, it's a different in a different way, but still can be seen in a home health setting.
Okay, makes sense.
And I'm Christina, working in an outpatient setting right now, and also a business owner, and I can kind of talk about both sides. Mm-hmm. The outpatient side, interdisciplinary communication looks like, talking to occupational therapists and physical therapists that share the same patient, communicating via Teams messages to physicians and asking them for referrals or asking them to give us support medically for certain patients. And then on a small business owner side, it's a little bit more difficult.
Do you feel like you have, I guess business owner wise, do you feel like you have a little bit more freedom as far as working with other, I guess?
I think they're harder to access.
Okay.
Like it's harder to figure out, what kind of occupational therapist I could reach out to that's not in a clinic. So interdisciplinary collaboration is mostly with other medical professionals, and then of course with the family members, because they're a huge part of the care team.
Okay.
Agreed.
Yeah, so now that we've talked about a few of the different settings and what interdisciplinary collaboration looks like, what are some of the problems that you guys have faced?
Oh, man.
I want to go first. So I definitely
jump in, Gabby.
I definitely came across someone, another clinician, and who did not receive any help positively, who was not open at all to working or collaborating with another discipline. which I respect. Everyone kind of can have their own way of treating, doing your own job. But so that's definitely one hurdle is, coming across someone who does not want to work as a team, even if it means what's best for the patient. And, you just have to respect it because at the end of the day, we're all professionals and, that's, you do your job, I'll do mine if that's how you, but.
That's definitely a hurdle I've seen.
Yeah.
Definitely.
What's another hurdle you've seen, Joe?
Man.
As far as collaboration.
Well, more specifically from the skilled nursing facility side, I feel like scheduling is probably the biggest thing. Everybody, going to work has their own set of grooves. You know what I mean? Especially if I want to work with patients that need to get out of bed. Usually, you could go to the caregiver, like the CNAs. Try to coordinate, try to get stuff done. But unfortunately, I could empathize knowing that they have to see, 10 other people. But just the issue and just scheduling, trying to make both schedule meet in order for something to happen. Like
organizing it.
Exactly. I don't want to come off like, hey, I need this done, ABC, because I'm not trying to be your boss, you know. But at the same time, I'm trying, let's suppose this patient receive a medication at this time, right? The effective schedule, the effective schedule will be.
Yeah.
Yes. You can elaborate a little bit more.
Yeah. Well, like you said, about medication and stuff. I think at the end of the day, we have to respect the patient and, their wishes too. But sometimes it's like, 11, close to lunchtime. And, perhaps the patient has not gotten their morning meds, or perhaps the patient, they're not clean, they're not dressed. And we do rely on the nurses and the CNAs to sort of
caregivers
have things done on a timely manner.
Because they get the ship moving, ship. You want to clarify that, y'all?
Yeah. SHIP, yes.
They do get it kind of moving.
I think that's where a hurdle could come in, like if you've been waiting on a patient, but in the meantime been treating other people who are ready. And then, you could be set back on your time because perhaps other people have not yet gotten to their job yet. So I think that's another hurdle in a skilled nursing facility.
And I definitely want to chime in as far as, because we all are relying upon insurance to reimburse our services. And sometimes the way that services are billed does not permit a lot of interdisciplinary collaboration, because if you can't bill for it, it may not be possible. Even though it, like we've talked about this before, it could be within the patient's best interest. So that's a huge hurdle. Sometimes I know, like Gabby was saying, personal preference, not knowing what other professionals do, right? So not really from a medical standpoint. A lot of times, some physicians, it's becoming less and less so now, but some physicians are like, what is speech therapy?
Exactly.
Or caregivers, really not understanding what the roles of each of the therapists that are involved in the care of their loved one or their patient is, and that can be a hurdle too. There's lack of information.
I do have a question for Christina. In a perfect world, what does a good collaboration look like with speech therapists and physical therapists? So, like, outside looking in, I'm thinking you're just just before I knew what speech therapy actually was. I'm thinking you're just here to help people with their speech. But, the more I talk to you, and the more I'm more familiar with speech therapists, obviously it's more than just, speech.
Valid.
So in a perfect world, what does a good collaboration with a physical therapist or even occupational therapist, what does that look like?
A lot of time it's communicating, behind the scenes where you say, I noticed that there are some cognitive areas that require support. So if you're giving this patient directions, make sure you do one at a time. Make sure you're using visual cues. Make sure that you're allowing for additional processing time. So this patient may need some extra time to understand your directions and then follow through. Creating communication boards for some of our patients that have had strokes and need that extra source of communication, and making sure that it's consistent.
So like good carryover.
Yeah, good carryover. And when I'm working with physical therapists or occupational therapists saying, hey, what are you guys working on in PT? Oh, you're working on transfers or sit to stands. Let me reinforce that in therapy by sequencing those steps and having the patient repeat them back to me and do them over again. So it's extra practice, right?
I did had a speech therapist coincidentally yesterday. I was, hey, like, what's your goals for like, for physical therapy? Like, because outside of you, like, I think working with you, you're the first speech therapist where we actually did like, collaborative effort. So when she came in and asked, I got thrown back like, let me transfer. So she said, okay, I can do ABCDFG, help with memory recall with this patient, and then if you want to like join in or chime in as far as to help assist with the carryover, then we could do that. So I think in a perfect world,
that's what it would look
like.
Like
Piggyback off of each other.
Exactly.
And I know that when we used to work together, you really did see the progress in the patient. When she would go and do her individual session and work on steps 1, 2, and 3. We're not going to 5, 6, and 7 yet. We want to get these down. And I really did see like safety awareness improve and carry over when it came to transfers, gait, or even just sequencing getting out of bed. For some people, like that's a huge win alone.
Yeah, or being able to walk and talk, right?
Exactly.
Yeah.
Being able to divide your attention and alternate between, your therapist giving you instructions and having a conversation. So I really did appreciate my physical therapy colleagues, of course.
And occupational.
Not in the room to represent themselves, but okay. But I did appreciate when we were able to get together and talk, and the patient just felt like they were taken care of as a whole, and that they had a team standing behind them versus one person versus another person versus another person.
And they actually, I feel like the patients look like, to me, they enjoy the rehab process a little bit more.
Yeah.
We have different personalities, but we are invested, obviously, in their health. And this almost gives an extra incentive to like, okay, I need to get my butt up out of bed. I need to participate.
Yeah.
I need to do A, B, C, D, F, G. And then, I feel like that makes therapy fun, not only for the patient, but for us, because we could easily go through like the mundane things of life, go through like almost a cookie cutter behavior.
Yeah.
But just bouncing different ideas with other people definitely makes, in my opinion, therapy.
Like switching it up.
Exactly.
Well, I want to like bring up another point, one that I honestly have not worked in before, but I think Christina has, is most of the experience that we've had was perhaps on the geriatric end.
Okay.
But what about pediatrics? I know speech works very close with occupational therapy with children who are having early developmental
neurological
delays.
Disorders.
Right or wrong, that you guys can work really well.
Yeah, I've worked with the whole team actually.
To improve early milestones.
Yeah, so way back when, I'm not gonna say how long ago, but I did work in toddler learning center, and I worked very closely with physical therapists, occupational therapists, early intervention educators, and it was a wonderful thing to see how the whole child was able to progress through milestones like walking and feeding and sensory management and swallowing at 1 month to 2 months to 3 years old. So it was really cool to see how the child and the family felt so supported by interdisciplinary collaboration. So I know that we would often have the PT come in and work on gross motor, and it was a lot of play therapy and let's get you to climb over the bridge and go down the slide and crawl across the floor.
And see, some people will see it just as that, as crawling across the floor, but as physical therapists,
milestones,
we know that we're working on shoulder stability, quadruped position. You're engaging those abdominal muscles that are important for being able to hold yourself up as a toddler or a baby who has maybe didn't get sufficient tummy time, or maybe spent too much time on their back, so their little abs did not develop and
can't support them.
Exactly. And in crawling or facilitating that next step in development is huge.
Help with the end goal of walking.
Exactly.
Yeah, and a lot of times, what I noticed was people observe other children and they think it should be a natural process for a baby to start rolling over and crawling, but if it doesn't come to them, then what? So really having the physical therapist come in and provide their expertise and education to the caregivers and family members is huge. And even to other professionals, because I have often asked Gabby and Joe, hey, what do I do to get this patient? Like, what do I need to talk about when I want this patient to sit up? Because I sit up in my bed without thinking, but here I am trying to tell a patient, like, this is how you gotta sequence the steps to get up. What goes first? Is it the arm, the leg? When do you bend at the waist? How do you hold yourself up if you're going to the side?
Left, right, yeah.
And I think a lot of that is just really figuring out what can my patient do and not do.
Yeah.
And that's where you start.
Yeah.
So we've talked a lot about benefits of collaborating and interdisciplinary work. What are some of the drawbacks?
The drawbacks to interdisciplinary work.
Too many hands in the pot. It could,
I mean, there's not that many if you're thinking about drawbacks. I think it's just really hard to get a whole team to work together and communicate. It can be a little time consuming to try to organize that effort, like we talked about before, different schedules, and if you're talking about collaborating with doctors or nurses, they're not always
Catch them when you can.
readily available to you.
And also, like, designated time frames, I have 30 minutes with a patient. I can only do so much, in 30 minutes, So we just have to learning how to prioritize. So, like Christina was saying, we probably have to plan ahead. We can't just jump in like, hey, come help me with this person. So if we could just have like early communication, like, hey, like this time of the week or this time of the day, we could try to do this with this patient, come together, help try to reach their goals.
Well, and like you were saying, you get an allotted amount of time and you're supposed to do your job, especially in some settings, in that amount of time, and there's not a lot of wiggle room. So one of the points we wanted to talk about today was how do you advocate for some extra time for that interdisciplinary collaboration to be planned so that the patient can benefit.
I think a big part of that will just be your documentation, stating why this method of delivering our session is better than an individualized treatment. That's, I think, one way we could probably justify getting, one more unit.
Exactly.
So in a skilled nursing facility, like if you wanted to see a little more planning time for interdisciplinary collaboration, who would you talk to?
I usually go to the director of rehab.
Okay.
I usually, hey, I'm working, let's say it's like a complex patient, let's say a stroke, right? And we know that we have let's say 2 weeks. Let's say we have 2 weeks to get something done. This person lives with a significant other, right? And we want to be able to, I guess, set functional goals such as, let's say, prolonged standing or being able to work on reaching, so it could help that carry over for not only himself, but that spouse is going to take care of him, right?
So essentially our goal would be for them to have some level of independence when they go back.
Exactly.
Yeah.
And so advocating that this interdisciplinary work would shorten the amount of time that it would take the patient to get to that goal.
Yeah.
Right, for independence?
Yeah.
Okay. Yeah, because I know that unfortunately, it's our healthcare system, but everything happens in insurance dollars. So if we can make a good case for it, it could happen. I'm sure shortening the length of stay and getting the patient back to their most naturalistic environment is a good way to advocate for that.
Now, I know in home health therapy, I work for 2 companies, but one company in particular, it's based off of like your time frame. So say I start at 3:00. I'm supposed to end around 3:45-ish. They kind of give you liberty to determine how much
wiggle room
or how little the patient really needs. but there is like always like a minimum. So I was told 35 minutes is like the minimum time. Anything beyond that, it's up to you, but you're getting paid for this particular time. Now, when it comes to interdisciplinary work, they want your in and outs to be different from another discipline's in and out time. So with my particular company, I'm not too sure that I can actually work directly with another clinician and us get billed
proper reimbursement
accordingly, like to each. So I think that'd be
that's a topic for conversation, right? How do you do this in a home health setting where billing is a little bit different and you don't have access to individuals?
Right.
I mean, it would be nice if home health companies promoted, communication, electronic communication that can happen in that little wiggle room that they give you.
Yeah.
And still be covered by the reimbursement that they're getting for the patient.
Yes.
I mean, it's definitely one of the hurdles to interdisciplinary collaboration that needs to be overcome, but now we're talking about it, so that's a good thing.
Yeah.
How about any funny stories that you can think of?
Positive or?
Just funny.
Just funny. Okay. Give me a moment. Think of something.
I don't know. So that's a very... I've got to think about a funny story recently.
I mean, I just want to be very transparent and blunt. And like sometimes working in these settings, you see things that perhaps you were not prepared to see.
Yeah.
You almost like, for example, I have my sister-in-law. She's a nurse. She works in cardiac surgery only. So she's a surgery nurse, and she says that honestly, in order for them to get through some of these operations, there's some sort of like dark humor within that environment to like compartmentalize what you're actually doing. Right. So there's been some times where perhaps me and maybe a coda or a speech therapist has, we saw something that in the moment with this particular patient, like it was probably like a funny incident, but I mean, it's kind of hard to talk about it without putting a lot of details out there.
No, I got it.
I will say my first week when I first started working, right after graduating, physical therapy, so was not educated in any way in my program on how to deal with pericare.
Oh yeah.
Or how to even go about that. Yeah. And I was probably 21 years old or 22 or something like that. Very green.
Yeah.
And getting thrown into a skilled nursing facility where there may not always be a whole lot of patient privacy when you're trying to work on getting out of bed. Perhaps your patient has a catheter. You got to try to make that a more comfortable situation.
Exactly.
Like, I think for me, initially, maybe some of those moments might have been like funny moments, but then I was like, that like, the glasses, the window that I had in between.
The rose-colored glasses.
I was like, okay, gone. Like, we're going bare. Like, this is what the truth and the reality of the situation is sometimes, you got to do things you were not prepared to do. But you overcome it because you realize that they're a person. But I think it could still be a funny incident.
Yeah, or, when you have a patient propose to you several times a day and ask you if you're still married. I mean, those are the funny moments that you experience in therapy, or when you are like, I'm going to collaborate with my favorite team member and we're going to go see this patient and have a lot of fun. And it's like, nope, ain't happening. That patient's been on the toilet all day.
I had some awkward situations where a patient tried to not help me, I'm not lie, where a patient thought he was trying to help me by trying to get me with a coworker. And that's just... You
gotta love it.
Yeah, that just makes the whole thing just... It's like, all right, buddy, let's stick to the topic. Your health. But
I mean,
yeah. So
those are the best moments. I love the fact when I can work with patients and they laugh too.
Exactly.
You bring some levity to a pretty heavy situation, like Gabby was saying, by being human and vulnerable and having those moments.
Yeah.
So.
And I think learning to not take things too serious as well.
That's the biggest thing. Is not
like something
things.
happened to you. Oh well, that's
Oh, you know what?
Part of the session.
I think.
Right.
I think.
On to the next patient.
There is actually a patient I work with. Didn't like my guts for whatever reason. Dementia patient. I would preface that. But that same patient did like another coworker as far as like working with an occupational therapist. And I guess the way I was able to even work with him is I'll go in, with the occupational therapist, hey, about your friend, we're gonna work together on getting ABCD done.
Yeah.
You know what I mean? So I feel like that's one superpower. Working with other people definitely helps, bring as far as patient care, as well as getting my job done as well, so. For
sure. And getting called all types of names. I mean, there's so many good and bad, having foreign objects thrown your way. It's the wonderful thing of and the comical thing of therapy.
And you had to deal with, not, I guess, arguments, but like anything where it's just like, all right, this person is crossing my boundaries almost, like, testing my patience. Not patient profile, but like another coworker. Like you're trying to get job done and this coworker's just like,
butting heads with you.
Stuff that you see in the interview questions. How would you deal with, until it actually happens,
Well, I think if it's that situation, like say with you and like perhaps another patient, like I definitely have learned to not take anything personal.
Yeah,
right.
No, definitely.
If it's me with like another healthcare professional, I mean,
ooh, that's tricky. Yeah,
I feel like I personally still try to not make it personal because I'm like, as long as I do my job, you can hate, you can dislike me, whatever you want. I'm still gonna go in, do my time, do what I gotta do. You're either part of it or you're out. Like, I'm gonna do my thing with my patient. If you would like to stay and hang out, if you would like to assist in any way you can, go for it. If not, clear the room. I got things to do.
Right. Oof,
and I try to do it in the most professional way. Like sometimes I could say something really mean with a smile, but I mean,
I guess
still professional.
In most cases, when I do see, that I like almost a passive aggressive or like some tension between coworkers, I find it sometimes to be that, that particular person is just having a bad day or just extremely stressed. Because they'll see you the following day, hey, how you doing? You know what I mean?
Yeah.
During that moment where it was totally a different vibe, you know what I mean? So I guess it kind of go back to what you said, like, just don't take it personal.
Yeah, I think like Gabby, that was the best advice because sometimes you will work with people that don't see your value, that don't really think that you belong in their space. And so you really just have to not take it personally, like Gabby said, hold your own and know that you're very capable. You're there to work with your patients and, make the best out of it. However, this is my big caveat. If it gets to a point where it's becoming really like abusive or there's, it's persistent and you've tried to, kind of brush it off and it's not working, then at that point, obviously get your directors or, whomever you need
higher
involved.
Up, someone involved, just so that they're aware of the situation and perhaps.
So wrapping this up really quickly, how do we want to say goodbye?
All right. Before we say goodbye, feel free to, if you guys, we appreciate your time, listen to this podcast. This is our first episode outside of our pilot. Feel free to drop any suggestions on what you guys would like to hear. I would like to wrap it up as far as that I'm appreciative of these two, coming in together. We met each other, 2 years ago?
Yeah,
Okay.
Year and a
roughly
half,
2 years
right?
ago.
You know, and they're awesome people. So I was just hopefully this.
Ditto, Joe.
Yeah, hopefully this podcast will be like a good like stress reliever or not even a stress reliever per se, but just more as
Yeah.
I think a safe space for us
conversations.
to talk about the things that we go through at work. Because I know, for example, my husband doesn't get at all like what I do in a skilled nursing facility.
1 year out the other kind of thing.
Yeah.
Well,
So
can't relate, can't empathize.
Yeah.
Really
but I mean
as
the
much.
same thing. I mean
They'd be like, "What are you doing all day? You're just moving people's knees. It can't be that hard." Yeah. Just
literally. Why
What did you make talk today, Christina?
It's just like.
But to add to what Joe said, thank you for listening. If you guys have any comments about anything that we mentioned today, any questions,
Put 'em in the
any
comments.
suggestions, put it in the comments. We might read our comments and pick yours next time. So
yeah.
We're
And
going
I
to-
definitely, by the way, I definitely wanted to say that this was a really great example of how interdisciplinary collaboration resulted in a true and genuine friendship and collaboration outside of our respective work settings. So
See, that's why she wanted to close it out.
that's why I wanted to close it out. All right,
Okay.
now.
All right, bye,
guys,
y'all.
thanks.
Thank you.
See you next time.